What's up, everybody? How you guys doing today? Well, it is again a Wednesday night, and like every Wednesday, you know what's happening. You know it's Vets Talk. This is the time we take the occasion to sit down to talk with a veteran from a different background and discuss a lot of stuff, a lot of issues sometimes, and most importantly, get ourselves a chance to know one another. Tonight, I have a special guest with me, which is Dr. Rivera. We're gonna talk to us about research study and how you can involve as an individual in a medical research study. But before we start, I just want to say thank you for everybody who called me last week and continue to reach out to me and send me a message this week. As you know, I am Haitian American, and yes, I am aware of what's going on at our border crossing in Texas. And all of you send messages, and I appreciate it. And my prayers go to those down there in Texas right now. We have friends and family who's doing an amazing job down there, helping the best they can. And we'll continue to provide our support as well in any way possible. And once again, thank you. I have the pleasure to have with us tonight Dr. Rivera, which is a board certified emergency physician and a researcher. He is going to talk to us about different things. Maybe for me, there's a lot of stuff going on in the research area or the research industry that I'm not aware of it, and I'm actually think I'm not the only one. I'm sure there's a lot of people who's not aware of it. Opportunities, how research is conducted, how you can get involved, how you can be a participant. So all of those we're going to discuss tonight, and I'm asking you to join us. If you are listening to me or watching me tonight, feel free to comment and let us know where you are watching. That way we can give you a shout out. If you're in a different state or a different city, let us know. So that way we can send you a shout out so we can make you part of the stream as well. And if you have questions as well, please feel free to ask those questions. I'm asking you to put a Q in front of the questions. That way when I can quickly identify the question, and I can put the question on the screen if we can, so Dr. Rivera can answer your questions. Other than that, Dr. Rivera, how are you doing?
I'm doing great. Thank you for having me, Johnny.
Man, I appreciate it. When I called you and I said, Dr. Rivera, I know you're doing research now, and I wanted to know a little bit about it, and you said no problem, and you answered the call. So can you please tell the audience who you are? And a lot of people don't know that, because there's a lot of people that I work with, that you used to work with, don't know you're a veteran as well.
Yes, sir, I am. U.S. Air Force.
U.S. Air Force.
Yes, sir. That's probably the best service.
Oh, we're not gonna go in that competition right now.
No, all the branches are good, and I'm proud to be Air Force because we were able to support and provide help to the other branches. So I'm very happy with that. So as you said, I'm a board certified emergency physician. I've been in the medical, specifically in the emergency medicine arena, for the last 37 years. So I started out in 1984 as a GP, just working in the ER, moonlighting type thing, and spent about 3 years doing that. Realized that is a vast and fascinating area of medicine. So, realized that I needed to have a formal training. So I went and did my residency, 4 years of residency in emergency medicine. And during my residency, that's when I started my service. So I joined the military in 1987. In 1989. My data rank, is 1987 because of the reserve and that type of thing. But 89, I became active duty. Okay. So after I finished my residency, I went to Andrews Air Force Base. That's home of Air Force One, and did a tour of 2 years there. After which I was selected to be the first fellowship in emergency medicine in the history of the Air Force.
Wow.
So fellowship is a subspecialty training. Just like internal medicine, and then you do cardiology to become a cardiologist. In emergency medicine, there are also subspecialties.
Okay.
So I went and did the EMS pre-hospital care, and became a EMS physician as well. And I did that under the sponsorship of the Air Force as well.
Wow.
I did that in Michigan, in Royal Oak, William Bowman Hospital, in conjunction with University of Michigan. So, when I finished that, I went back to Shepherd Air Force Base and did a tour there as well. And then in 1997, separated, came to Orlando back then, and spent 4 years here as part of Florida Emergency Physicians, working in Florida hospital system. I was the medical director of the helicopter service for Florida Hospital, and then became associate medical director of the EMS system in the county. Then after 4 years here, I took a academic position back in Michigan, this time in Saginaw, which is now Central Michigan University program, but back then was Synergy Medical Education Alliance. Was assistant residency director there for emergency medicine, as well as the EMS medical director for a 2-county system. Spent about 8 years there, and got involved in a number of projects and a number of things, including SWAT physician, bioterrorism, disaster preparedness. Got involved in the Michigan Trauma Coalition at the state level, and the EMS coordinating committee. So had a bunch of different experiences, which were excellent. I learned a lot from a bunch of experts that in emergency medicine that are in Michigan, that I have the privilege to call my friends and mentors. So after that, decided to come back here to Orlando, was closer to home, closer to family, and then have been doing clinical emergency medicine here in Orlando since 2008. My most recent job was with Guidewell Emergency Doctors, which is an advanced emergency medicine / urgent care. And then I recently joined Charter Research, which is a company dedicated to medical research and clinical trials. So I am a full-time researcher with them as a principal investigator, and I'm enjoying my time. Is a great move. I'm very happy with that decision.
Man, Doc,
and here I am tonight.
Doc, you've been at this for a long time. So
yeah,
what make you decide to go to the medical research way? I mean, you've been at emergency medicine. You've been doing it both as an active duty, do it in the civilian world. And I mean, you have more than 30-something years in the medical field. So why now you decide? What make you decide to go the research way?
Well, I always had that little bug because back in my fellowship, part of the training was doing research, and my fellowship director and mentor was a big researcher as well. So I was exposed then to research, and a little while later, concomitant with that actually, I was doing my master's in public health. During the master's in public health, part of the curriculum was biostatistics, epidemiology, and research, applied research. So that part sparked my interest really in a way that I didn't realize that I was going to like it. But again, it's not too much long. A 2-year fellowship, 2-year master's in public health. It's not too long, so you just get a taste, and then you never get to develop that. Then when I went to academics, as assistant residency director, that also required part of my job to be involved in research and to mentor. This time, I had been mentored. Now this time to mentor other younger physicians that were the residents. So I get involved in research with them. We had several projects going. We presented the projects in different forums, and 2 years in a row we had an award of best oral presentation with one of my residents, me as the faculty. So that really, I like it a lot. But I was doing so many other things that, again, I didn't have much time to dedicate to research. So that was always in the back of my mind as an unfinished business, so to speak. And this opportunity presented itself, and I just jumped into it.
Wow, nice. So, when we talk about research, it's two things. People either take it as a huge, huge deal, or people say, well, I don't know what it is, and they just close their eyes. Now, can you kind of break down to us what is medical research? What is involved when we talk about medical research? Because nowadays with the vaccine and all of that, people are talking about it's not enough research, it's not this, it's not that. Can you break down for us what is that medical research that everybody's talking about? Like break it down like we were in elementary school, so we can understand exactly what is that.
Yeah, definitely, and that you're absolutely right. Sometimes it's a little scary. Some people say, "No, I don't want to be involved with research. I don't want people playing with me," and other people just don't know anything. Now, with the situation of COVID, it has come more into the mainstream, talking about research, talking about the vaccines as they are being approved or not approved, or emergency approval. Experimental drug, and so forth and so on. So you can cut research in different ways. One of the ways is population type research, where you're studying groups, you're studying big populations, disease in populations, and that's more of an epidemiological type research.
Okay.
So that's a little bit obscure to us, because in the personal plane, we don't participate from those studies. As a group, yes, we do. They're studying us indirectly as a group, but not individual. Then you have sort of academic research as well, which is they call it basic science or bench research. That's the one that they are in a lab studying different things in a petri dish under a microscope on laboratory animals, animal models, and things like that. So that's much more of a pure basic research, bench research, and by the way, that's the way that it gets into the actual clinical research. You can't get into clinical research without going through those steps, so that you can see if what you're studying is safe or not.
Okay.
And then it comes into the actual clinical research. The clinical research has four phases, and the same thing happens. The first phase is a small study of few healthy individuals that volunteer. They get the different medications or device or whatever it is that you're studying, and then you kind of like have an idea of what was the effect on those healthy individuals. Then you get to phase 2, which is now a little bigger group that has healthy individuals, but also have some individuals with the disease or the condition or the situation that you're studying.
Okay.
And that's also controlled. Go ahead.
Now, who can participate in the research studies?
Okay, so let me fast forward to phase 3, which is the one that is more pertinent to that question. So who can participate on phase 3? Phase 3 now is the bigger study with a lot of people. We're talking hundreds to thousands, and now you are applying the knowledge that you gather from all the other phases into that phase. Who can participate? It depends on the study. So many of the answers I'm going to say, I'm going to use that phrase. It depends on the study, because you design the study based on the research question. What is it that you want to answer with your research? And based on that, then you design the study, and within that design, you put a list of inclusion criteria and exclusion criteria. And based on those criteria, then that tells you who can participate. That's why what we do in chartered research is we bring the individual that is interested in a particular study or particular condition. We bring them in, we do an assessment, or what we call a pre-screening process, to see what the medical history is, what medicines they're taking, what condition do they have, is it advanced or not. And then with that, then we can say, okay, based on your situation, you are eligible for this study X, or you're eligible for study Y, depending on what studies we're running.
Oh, okay. So even if I volunteer, that doesn't mean I'm going to get to, let's say I volunteer for this study, I might not get this study. It's based on, after the screening, is based on what, like, my body is telling you is qualified to participate.
Exactly. So there are, let's use Alzheimer's as an example, because Alzheimer's is a fascinating disease that is devastating and causing a lot of problems, and we still don't have a cure. We still don't have a treatment that is disease altering. We have treatment that treat the symptoms, but we still don't have a disease altering treatment for that condition. So let's say you have concerns with your memory. So you're interested in getting into an Alzheimer's study. So when you come in, we do the pre-screening. It turns out that the study that you were interested in, because somebody told you, you saw it in the paper, you saw an ad, or what have you, then it turns out that your memory problem is either not enough to be part of the study, or your problem is way too advanced to be part of that particular study. Now, it could be that the memory problem is the appropriate one. Then you jump into a different stage of the screening, and we may do an MRI, or we may do a PET scan looking for protein deposits that they're called amyloid and tau, two different proteins. And you may not have enough of that protein accumulation or deposits. They're called plaques, or you may have too much. And again, it has to be within a parameter that study is designed for. Or maybe like, okay, you are not eligible for this particular study that you came in for, but by the way, we have this other study that we're also running that for that one you are eligible. And then you may come in for in an evaluation for that particular study and come out being part of a different study. Okay. So it all depends on your particular situation.
Okay. Now, do the subjects have to sign like some type of consent form that they agree to participate in that?
And that's exactly right. In fact, that is the first step before we can talk to you about anything in your medical study, medical history. Before we can talk to you about anything else, you have to consent for us to gather that information. Okay. So you sign we explain to you what the consent is, all the steps, then you read it on your own, and then you sign if you agree with that. Once you do that, then we get that pre-screening situation going, and then when we put you into a specific study, or we tell you that you're eligible for a study, then when you are going to enter that study, before we can do anything with you for that study, then there is a specific formal consent for that particular study. And each one of them being different, they also going to have different consent process. Because some of them you're going to receive a drug IV, some of them you may receive a drug orally, some of them you may not receive a drug, some of them may require a procedure like a lumbar puncture, which is a spinal tap, or anything like that. So the consent is going to be different based on each study, and you have to understand everything that is going to go on in order to consent for that.
Now, us like the regular folks, sometimes I think most of the big questions, I think the big questions to ask is, I mean, what is the benefit for me, like as an individual, to participate in a research study? I mean, I know, I think that's what most people ask themselves. And sometimes it's hard to find somebody to answer that question. So I'm glad you're here today. So for us, the regular folks, what is the benefit for us to participate like on a study like that?
Okay, so that's an excellent question. Is, as you said, is probably the most common question that we get. I personally like to answer it a little bit backwards. Before you think about what is the benefit for you, I like to tell people, think about what is the benefit in general. What is the benefit for my society, for my community? For instance, if you have a headache and you take a Tylenol, you're taking that Tylenol thanks to a number of individuals that volunteered to study that drug at the time that that drug was developed and before putting it in the market. So you are benefiting from something that somebody else volunteered to be part of. So thanks to them, you can treat your headache with a Tylenol. Same thing with any other drug that you can imagine. They have to go through all this process. So now you have mild Alzheimer's, or you have what we call mild cognitive impairment, which is not quite Alzheimer's yet, but is already a mild impairment in your memory and your cognitive condition. So now you're concerned about that. So think about, if I'm concerned now and there is no medicine, no cure for this disease, can I be part of something that will find that cure, will find that medicine? So in 10 years, in 5 years, in 20 years, somebody with my condition today can then take a medicine that is going to make them better and cured. So that's what I like to tell people to think about first. Now, secondary, that's going to be your main benefit. You're helping other people with your condition going through what you're going right now to be better in the future. After that, then as a secondary benefit, as a side benefit, then there are some benefits for you. Some study you get more benefits than other studies. For example, we have studies that are not interventional in terms of medicines. We're not giving any medicine to anyone, but we're bringing you in. We're getting some blood work. We're getting physical exam, electrocardiograms, MRIs, PET scan, and genetic testing. And with that, then we can advance the research field into Alzheimer's and understand the disease better. You didn't get anything directly, any benefit directly, but you help your fellow citizens. However, some of these things, like let's say the PET scan, the amyloid PET scan, or the tau PET scan, those scans are not done regularly. You can't go, and you know a lot about this, being in that field yourself. You can't go and have a PET scan one day because you are having memory issues. They're not going to do it. The insurance companies are not going to cover it. The only thing that PET scans are being using routinely in the clinical setting is for cancers, different type of cancers, but not for neurodegenerative diseases like Alzheimer's or Parkinson. So now, if you're part of this study, even if you don't get any intervention to directly benefit you, you had a comprehensive workup done, blood workup, comprehensive physical exam, and then those PET scans. Now you have information about yourself that then you can use later on, in another way.
Now, the other concern some people have is the worry about risk. Now, how big are the risks? Are they very minimal, or is even any risk involved at all?
Well, there's risk involved in anything just because you're alive. You know, you cross the street.
There is risk just because you're alive. I like that.
Absolutely. You know, you cross the street and you can be killed by a car. You are standing in a line in the grocery store and somebody cough on you and now you got COVID.
Yeah.
And you may end up intubated and die. So you're taking a shower, you slip and fall and hit your head and you may die. So there is a risk for everything. So I cannot responsibly say, oh, the risks are not too much, they're minimal. There is definitely risk involved. Now, like everything in medicine, you have to put it in a balance. How much risk versus how much benefit I'm willing to take. So depending, again, I told you, depending on the study, there are going to be more risk than other. If it's a study that just you come in, get the blood work, get the physical exam, and you go home, then the risks are going to be much less than a study that runs for 2 years on a monthly basis, receiving an IV infusion of an hour. So that study is going to have more risk than others. So it depends on the particular study, and that's why we go through the consent process to explain to the participant, the patient, what are the studies for this particular. I'm sorry. What are the study? What are the risks for this particular study, and what mitigating factors, what processes we have in place for this particular study to protect you. I can tell you that every study is very, very rigorously regulated by the federal system, specifically the FDA. Super rigorous regulations on that. I can tell you that there is an entity called Institutional Review Board. This is an entity that is not affiliated with anyone in particular, so they're a standalone, and the whole sense of existence is to make sure that the patient is protected at all times. And then there are different echelons, and one of them, the one that you interact with the most, is me. Mm-hmm. So the study doctor is going to be the main concern for that study doctor is the protection of that patient. The sponsor is not seeing that. The sponsor is the one that puts the money to develop these studies, and the sponsor is not necessarily seeing the patient as an individual. They're seeing the aggregate data for all the participants and all the sites, because some studies will have few sites, 10, 12 sites. Other studies will have 200 sites, depending on how many patients they are looking for. Some studies are only in the U.S., some studies are global, so all over the world. So the sponsors are not seeing those patients directly. Who's seeing those patients on a regular basis every day that they come into the clinic for any intervention? The study doctor. And therefore, our main concern is to make sure that particular patient is safe. Then the design of the study has embedded into it a safety issues where they can actually now I just mentioned the sponsor looking at the aggregate data. So let's say my patients in my site have not had any issues whatsoever. They are fine, no side effects, no problems. But other sites have had side effects. So the sponsor is seeing that aggregate data, and now they're saying, wait a minute, we're having too many, brain bleed, just to use an example.
Okay.
And they may say, wait a minute, there's too many brain bleeds. We have had already 5, 6, 7, 10, 15. Even though none of my patients in my site had it, the sponsor can say, we're going to stop it. We're not going to continue because it's too risky. and that's based on the design of the study.
Okay. Now, it's interesting what you mentioned that during the research process, who will take charge of the patient care? Like I'm talking about if something happened, because I know, like, will the facility, like for example, your facility, which is a charter research, will they take care of that patient if something happened during the study itself?
Very, very good question. Excellent question. So the quick answer is no, because we are not a treatment facility. We're a research facility. That's the quick answer. However, we have to qualify that. So we are equipped with basic emergency drugs and equipment to take care of that person immediately. And as an emergency physician, that's what naturally I'm going to do, is to take care of that patient immediately, depending on what's going on with that patient. However, if it's a big emergency at the point, let's say an anaphylactic reaction from allergy to that medicine, then we're going to call 911 right away, and the patient is going to be transferred to the ER. Now, if the problem is less urgent, the problem are just some side effects, nausea, vomiting, a little bit of dizziness, things like that, then the patient is going to either call or come and visit us. And then at that point, if we establish that there is those symptoms, then we're going to send the patient to their primary doctor.
Now,
primary doctor.
You know where I'm heading this way now. Like let's say the patient had to go to the ER or whatever. Now let's talk about the bill area. Like, will the research facility cover that bill? Because the reason I'm asking those questions, there's a lot of people who's afraid to go be a participant because they don't know the answer to those questions. Now, will the research facility cover that bill?
Yes, and that's part of the consenting process. We explain all this in detail, not only verbally but in writing. All this is in writing. So, as a general rule, and again, I'm using the same phrase. It depends on the study.
Yeah.
But as a general rule, everything that happens that is related or a direct effect from participating in the study is going to be covered by the sponsor. So let's say that we give you the medicine, you develop an anaphylactic reaction, we call 911, you get to the hospital via ambulance, all those bills are going to be covered by the sponsor.
Okay.
If you have symptoms that is determined not to be part of the or a direct result of your participating in the study, for example, you are in the grocery store, you slip and fall.
Yeah.
And
that's
so
different.
you happen to be in a research study, but that doesn't have to anything to do.
Of course.
And
I like
you'll
that.
be surprised. Some people will come into the to the research center, and then something happens. Oh, that was because I was there. No. So again, as a general rule, if it is related to the study, the sponsor is going to pick up the bill 100%. Now, the caveat is you may initially be charged to your insurance company when you go to the ER, because that's what they're going to take your insurance and all that information, and your insurance may be the one being billed. But that doesn't mean you're going to have to pay at the end out of your pocket. That means that the insurance company and the sponsor are going to talk to each other at that point and determine, no, it's not your bill, it's my bill, I'm going to pay for it.
That's good information, and we've been talking for a while. And there's a portion that I really want to touch. In our community, memory loss play a big role. And
oh my gosh, yes.
Yeah, and I would like you to take a moment to talk about. I know you're involved in the Alzheimer's disease research right now. Can you tell us a little bit about it and tell us the process if somebody want to get involved, what's need to happen?
Yes, that will be great. In fact, Chartered Research, well, we do research in a variety of areas, but we tend to um, specialize in Alzheimer's and Parkinson's. And right now, I would say that at least 3/4 of the study, if not more of those, are Alzheimer's that we're running at this particular moment. Because again, Alzheimer's is very problematic. It's a devastating disease for the patient and the family, and for the society as a whole. So you have up there some statistics. Let me start saying, up in the right, the first statistic that you see in this graphic is discrimination. Let me start by using a little bit of a disclaimer. This is put up by the Alzheimer's Association, and these figures are very well researched, and they're based on hard data. This is not opinion. However, when you ask a patient about if they were treated correctly or not, that part is more of an opinion, it's more of a perception of that patient in particular. But it's still interesting, whether it's an opinion or not. It's very interesting. You notice there that half of the patients that are Black Americans, they perceive that, half of them perceive that they had discrimination as a barrier to obtain the right medical care for Alzheimer's. But that is across the board. You see that even the lower one, which is the patients that are Hispanic or Latino Americans, they perceive, 1/3 of them perceive that they have discrimination as a barrier. So I just want to take that up front so we can take that out of the way. Whether it is true or not, it is the perception of the patient, and this is hard data from that perception. Okay, so moving down, see that 6 million and probably 6.2, 6.3 million Americans today are suffering from Alzheimer's. Wow. Now that's not even including the MCI that I mentioned before, which is mild cognitive impairment. That MCI may or may not be a result of Alzheimer's. So you may have MCI that is not Alzheimer's. So this is Americans that are diagnosed as Alzheimer's properly. So that's 6.2, 6.3 million is a lot of people. And if you see over on the right-hand side, probably the left on the screen, it says that over 11 million of Americans provide unpaid care for these patients. That means that they are being taken care of by family, friends, or even some institutions that don't get paid for that. So that's about $257 billion that is being invested by people that don't get reimbursed about that. So that's a big hit in our community pocket.
Why?
Well, that's a good question. Why? A variety of possible reasons. Alzheimer's is so devastating that many family want to take care of their loved one themselves, because in some institutions they don't take care. They perceive that they're not being taken care of appropriately. They may wander out and get lost and this and that. So there are many reasons why, but they decided that they are the best ones to take care of those patients.
Okay.
So it's a big hit for everyone involved. If you see on the far left lower corner, the disease itself kills more Americans than breast cancer and prostate cancer together, combined. And you know that breast cancer more than prostate cancer is a big problem. Is a disease that is also devastating, that is hitting a lot of Americans. Women, in this case, there is breast cancer in men, but it's so small and negligible that is mainly a woman's disease. and is devastating. But Alzheimer killing more people than breast cancer and prostate cancer together. That's a big deal as well.
So
If you see
you
just next,
you're saying there
go
were in
ahead.
between 2000 and 2019 there was a 145% increase death from
Yes, sir.
Alzheimer's disease.
Yes, sir. Yes, sir.
Oh man.
Compared to heart disease, cardiovascular diseases, that they decrease by 7.3%. In Alzheimer's, the death toll increased by 145%. That's a high increase in just a 20-year period.
Man.
So Alzheimer's is devastating. And what happens? Another interesting fact is Alzheimer's doesn't happen overnight. So Alzheimer is, we believe that one of the hallmark of Alzheimer's today is the deposits of the amyloid protein and the tau protein. So those deposits in the amyloid case is called plaques, and in the tau case is called tangles. Tangles, because they look like spaghetti that is all tangled in there. That deposit starts slowly over years, and it may take 10, 12, 20, up to 22 years to develop that. So you may be developing Alzheimer's for 20 years and you don't know it. You're fine. You're, quote unquote, healthy, cognitively speaking. And little do you know that you're developing that Alzheimer's. So it takes a long time to show up, and therefore it's difficult to diagnose on time.
Okay. Now, with that, are you seeing like an increase on younger folks with Alzheimer's disease symptoms, such as like they might be in the 60s or 50s, or can you tell us, approximately what age do you guys start seeing there's an increase or there's some signs and symptoms associated with this disease?
In general, we talk about the age group from 60 to 85. That's when all that group is where all these statistics are predicated on. Now, you can see Alzheimer's as early as 35 years old, but that's very, very rare and far between. You start seeing that, in the 40s, mid 40s, early 50s. That's when you see a little bit more. But many of these statistics are from 60 to 85. That's the bulk of the cases. Early Alzheimer's is there, but is less and not as frequent. Now, yes, you are right. It has increased. I believe about 5%, if I'm correct on that one. I'm not so sure, but I believe is that a little bit of increase over the years in the early Alzheimer's group as well.
Wow. So, Doc, what is your facility, Charter Research? What are you guys doing to help bring like a solution to this disease?
Well, we are dedicated to research, and as I said, our area we do a variety of research, but our area is of expertise is more Alzheimer's and neurodegenerative diseases.
Don't get me started with my accent, Doc.
Yeah, it's interesting, right?
I know.
So we do that. We have a number of projects, studies going right now. We have 3 sites. One is in Lady Lake, the Villages, and we have 2 sites here in Orlando, in Winter Park, both of them. And they are those 2 sites here in Winter Park are in close proximity because one is a neurology practice, a very busy neurology practice, Dr. Ramon Rodriguez. And the other one is our office, Charter Research, Winter Park specifically, and that's the one that I'm the principal investigator of. And so I'm full time, but we have about 4 or 5 different doctors that are part time, that they are running as principal investigators in a number of studies, anywhere from 1 to 8 or 10, depending on what's going on at a particular time. But they are part time because they have their own practice. The same thing happens in Lady Lake. Dr. Jeffrey Norton is the full-time principal investigator at that site, and there's also 4 or 5 different part-timers that, I call them part-timers. You can call them consultants that are from different specialties. Dr. Smirnov is a neurologist that is also very involved there, and so we as the full-time physicians, we have a lot of resources that we can tap into. In addition to that, our team is vast. We have clinical research coordinators, we have research assistants, we have psychometric raters, master prepared. We have a plethora of experience and knowledge in our team. So they're gonna take you like a NASCAR car, and they're gonna jump on you from different angles. They tag team. You're gonna feel very comfortable with them. They are all very caring. It is a wonderful group of professionals.
Now,
so,
with that being
yes.
said, if somebody in our community or anybody who's watching this right here want to participate in the clinical research or medical research for Alzheimer's disease, what do they need to do?
They can call us directly at 407-337-1000, 407-337-1000, or they can access our webpage, charterresearch.com, CHARTERRESEARCH, charterresearch.com. And in that webpage, they have information that they can access. They have some videos as well, and there is an interest form that they can fill out, and it's going to go directly to us, and we will call them and bring them in for the pre-screening visit, and from that visit we can then decide where they can be placed.
Is it a specific age category, or are you taking any category if they're adults?
Correct. So again, the little phrase again, depending on the study. Some studies are running from 60 to 85, which is the main bulk of them. Some studies start at 55. Some study may go all the way up to 87. It's rare that any study is going to take anyone 90 years old. So it's usually lower than that. And it's rare that they will be taking any lower than 50. That doesn't mean that they won't take them. I'm just saying that is rare. The majority of them are somewhere between 50 and 85 in that age range. But again, there are sometimes some studies that may be outside of that. We are doing interventional studies, and we're doing non-interventional studies. We have right now 3 studies that are just looking for biomarkers. Remember that I told you about the slow onset of the protein deposits, and the fact that by the time you start exhibiting symptoms is a little bit too late in that sense. So one of the reasons is, in addition to that, is because the gold standard to diagnose the disease is to do a PET scan to identify the plaques of amyloid or the tangles of tau, and that's difficult to come by. It's almost impossible. So one of the reasons for these studies that I just mentioned is to look for biomarkers. In other words, to look for other ways via blood work or spinal tap or even retina scan that we can be able to do the diagnosis, or at least a screening test that is going to point us in the right direction early on, or earlier than we are now, and easier than we're now. Just like when you go to the ER with a chest pain, what do? They do an EKG. It's fast, it's easy, is quick to obtain. If you go with burning on urination, they do what? Urinalysis. Mm-hmm. So those are biomarkers. The same thing with this. We're looking for a way that if you have some symptoms, or even if you have concerns, then that we can do that type of biomarkers and find out if you are having the disease or not.
Now, I see an interesting sign behind you right there and your flyer. What is that? Win $5,000? That's what that said?
Yeah, no, that has nothing to do with Charter Research. That's the disclaimer.
I like it. I just have to.
But stay tuned, and maybe next month we can talk about that.
Well, here we go. Stay tuned. Maybe next month. So now that we talk about the part of research, and we talk about what's important for people to participate and help the community and help ourselves at the same time. But there's another part of it I think is very interesting, and this part is for those who want to be on your seat, or who want to be part of your team. So what is the process for the people who's going to watch this live, or who's going to watch it later on, to say, okay, well, I like what he's talking about. Not only I want to get involved to be a subject, but I would love to do something like that. Like, I have a lot of nurses in my community, and I have a lot of people in the medical field. So what is the process if they want to get involved and do something like you are doing?
Fantastic. So the same thing, the webpage, we have in the webpage posted the different roles that we're looking for right now. Mm-hmm. I can tell you, because our site in Winter Park is a relatively newer site, as opposed to the one in the villages, which is very established already. So our site in Winter Park it's been in existence probably for a little over a year, maybe, if that. So we're still in the growing phase, and we're hiring in different. We call them roles rather than position, because it's a role that you play within the research team, and they're posted in the web page. But it's funny that you mentioned nurses, because that's one of the roles that we're always looking for. Right now, when we give an infusion, we have to have a nurse that can come in and get the IV established, supervise the infusion. They don't have to prepare anything, because we have a pharmacist on staff, a doctor, PharmD, a doctor in pharmacy, that they do the mixing in a blinded fashion. The rest of us don't know what they're doing. Yeah. They are locked behind. They're behind a locked door, and they follow the design of the protocol to prepare the interventional product. And that could be the drug, or could be a placebo.
Yeah, that's just to maintain the integrity of the research.
Correct. So the nurse will come in, and she or he don't know what is in there. They just establish the IV, supervise the infusion, get vital signs, and then when the infusion is done, observe them for another hour, and then discharge the patient. So we are always looking for nurses that can do that. At this point, we have a pool of nurses that we can call based on the number of patients that we have for a particular day. In the future, as we grow more, then we may have more nurses on staff and or full-timers as part of the team.
Okay. Now,
but charterresearch.com, charterresearch.com. That's the way to go.
Now, the other question: does everybody on the team have to have medical background? Can somebody with no medical background, do you guys have roles for anybody with no medical background?
So yes, the answer is yes. The clinical research coordinators may or may not have a medical background. Some of them don't have medical background. Some of them have some medical background as a phlebotomist or as a scribe in the medical setting, or as an MA. But some of them don't have medical backgrounds at all, and their first exposure to medical research is through us, or through any other organization like ours. So the short answer is no, they don't have to. If they do, is a plus, but they don't have to. We will train them. And the training is pretty much standardized. So all these trainings are predicated on the National Institute of Health, and we all have to have the same different certifications of the different research processes.
Wow, that was a lot of information, and I appreciate how you come to VETS Talk and you are able to break it in pieces, both sides, and I mean, the only thing I can say, I'm amazed, man. There's a lot of information that I didn't know. I appreciate it, because I can tell you, me personally, I think when my grandmother was about 83, 84, she used to leave the house a lot and just go for a walk and just get lost. So, but I was young, and but when I mean young, not like a kid, I was still an adult, but I did not have the knowledge. I did not have the knowledge to even check for Alzheimer's disease or anything like that. It's amazing that you're able to come over here, and that helped me a lot, and I'm hoping this type of conversations are happening in our community, and hopefully more people take actions and more people volunteer, because I think somewhere in prior to doing the interview, you mentioned medication and stuff, but there's sometimes they don't give you medication, right? There's sometimes it might be a blood test, it might be just the control, it doesn't immediately say it's medication.
Correct. Yes.
Yeah, and I also appreciate the way you break it down. I mean, if you have so many barriers, this is probably one of the best system to go through, because it's so many level of protections that are in place to protect. Well, I don't know if you call them patient, if you call them subject, but to protect whoever volunteer to go through a research. I mean, you make me think, man, I need to participate in one, because it's good.
Well, it's funny that you mentioned, because my last remark here is the way you saw the first statistics that I mentioned about Black Americans, Latino Americans, and other minorities. We at Charter, we believe that these communities are underrepresented in research, and one of the possible reasons is exactly what you are addressing, which is that lack of knowledge of what is going on in research, what is going to happen, what does that mean, and what does that entail. So by educating our communities, we can hopefully get more participation from Black Americans, Latino Americans, Asian Americans, Native Americans, all those groups that right now. And by the way, for example, Alzheimer's, Black Americans are twice as likely to develop Alzheimer's. Latino Americans are 1.5 more at risk. So there you have two groups that are higher risk by far, but yet they are very low represented in these research studies. So we want to increase the awareness out there and increase the participation of these groups. We can do studies in Spanish right now, as it is. Our team is we have fully bilingual personnel in each one of the roles, and therefore we are approved to do Spanish research totally in Spanish. And you can't find that very often. We have people that come all the way from Ocala all the way here because we are the only one approved to do Spanish. in this area.
You know what I'm gonna say, Doc. You're gonna have to get approved to do some of those studies in Creole as well, because in Central Florida and Florida in general, it's a big Haitian population. So
absolutely, that is part of what we have as a vision. We don't have it right now because we need to get the IRBs, the institution that I mentioned to you before, to buy into the process to translate all these documents in that language, whatever the language is, in this case Creole, and then once they translate that, then they can approve it, and then we can have a staff member to do that in Creole.
Nice. Well, Doc, I appreciate your time. We've been at this for about an hour. I mean, you gave us so much information, and I'm sure this information is going to help somebody as we play this video over and over, and we purpose this video all over the net, and I'm hoping they will reach out to you. Once again, the information is at www.charterresearch.com. It's right under the name, under Dr. Rivera name. So if you are interested or if you have questions, go on that website, hit them up, trying to figure out what they're doing. And I'm sure on the website there's a place and they'll got a phone number, because I don't have the phone number in my head right now. I'm letting Doc give it to you after, but I'm sure there's a phone number you can call. But at least try to get the information so we can help ourselves, so we can help each other, okay? And it's very, very much appreciated that you take your time, Doc, to come and talk to us. And I'm giving you the final words. Here we go.
I appreciate you inviting me. I appreciate what you're doing for our communities, both veterans and minority communities. That's commendable. And I'm pleased for the audience listening out there. Please come forward. We can chat. We can evaluate you and see if you can benefit from one of these studies and help your fellow citizens, fellow community members to a better life. That's what we are all striving for, and these are one of the ways to do it. Thank you very much for your attention, and again, thank you for having me. Charterresearch.com.
Charterresearch.com. There you have it, ladies and gentlemen. Thank you very, very, very much for being here with us. For those of you who were under the live, who was watching with us, we appreciate you. We'll be back next Wednesday with another guest, where we'll talk about another subject. But today is all about research. Please, the information is at www.charterresearch.com. Go ahead, go to the website, figure out what's going on, because our community are not represented very well when it comes to this. As a result, we are the ones who are suffering when it's time to find a solution. So we have to do a part. Part of it is to be patients, subjects, or volunteer to be involved in this community and trying to be there and help. And like Dr. Rivera said earlier, that doesn't mean they're going to give you medication. That doesn't mean you're going to get selected. There's a very, very rigorous process to go through this. It is safe. Please, let's get out there and help each other. Dr. Rivera, thank you very much. Have a good night, everybody, and we'll catch you next time in VETS Talk.